Hello, my name is Arya Javidan, and I'm the Program Coordinator for the National Consortium of Telehealth Resource Centers. Welcome to the latest presentation in the NCTRC webinar series. Today's session is on the classic tale of the haves and the have-nots, disparities in telehealth availability in rural hospitals. Today's webinar is being hosted by the South Central Telehealth Resource Center. These webinars are designed to provide timely information and demonstrations to support and guide the development of your telehealth programs, and they are presented on the third Thursday of each month. Just to provide some background on the consortium, located throughout the country, there are 12 regional telehealth resource centers and 2 national, one focused on telehealth policy and the other on telehealth technology assessment. Each serve as focal points for advancing the effective use of telehealth and supporting access to telehealth services in rural and underserved communities. Just a few tips before we get started. Your audio has been muted for today's webinar. Please use the Q&A function of the Zoom platform to ask questions. Questions will be answered at the end of the presentation. Please note that closed captioning is also available for today's webinar, and it's located at the bottom of your screen. Today's session is being recorded, and you will be able to access today's and past webinars on the NCTRC YouTube channel. And with that, I will pass it over to Hari Iswaran, Director of the South Central Telehealth Resource Center.
Thank you, Arya. It's a pleasure for us from SCTRC to have a speaker, Dr. Salima Karim. She is an associate professor in the Department of Health Administration and College of Health Professionals at Virginia Commonwealth University. She teaches healthcare financial management to graduate students in the Masters of Health Administration program. Her research interests are rural hospital financial performance, geographical disparities, Medicaid expansion, hospital quality and access. And Dr. Karim is part of the Rural Telehealth Evaluation Center, which is at the University of Arkansas for Medical Sciences. And she is currently at the Virginia Commonwealth University. And this is one of the projects she had worked on and has a far-reaching implication for all of us. So I would welcome Dr. Karim to give us her insights for her talk today.
Great, thank you, Hari. Before we get started, I just want to share my screen. So just checking, can everyone see my slides? All right. Okay, so thank you all, and for such a kind introduction, Hari. It's a pleasure to be invited to share this research with you all. The title of my presentation is The Classic Tale of the Haves and Have-Nots, Disparities in Telehealth Availability in Rural Hospitals. So today's research presentation is part of a funded project by the Federal Office of Rural Health Policy, the U.S. Health Resources and Services Administration. So the original proposal and purpose of this grant is to assess the association of telehealth technology and financial performance in rural hospitals. And we're currently working on trying to answer this question. But the presentation that I will show you today will hopefully kind of came up midway as we were preparing our analysis and data for this overall objective. So my name is Salima Karim. I am currently an associate professor at VCU in the Department of Health Administration at the College of Health Professions. I am the project lead for this research proposal and very excited to share our research with you. I want to take this opportunity as well to acknowledge the hard work and effort of the Rural Telehealth Evaluation Center team at the University of Arkansas for Medical Sciences. So the title of my presentation is The Classic Tale of the Haves and Have-Nots, Disparities in Telehealth Availability in Rural Hospitals. So again, thank you all for taking time out of your day for attending this presentation. I hope this presentation and research topic will be informative and generate some thoughtful discussion and future ideas on this or other potential topics. this team, the Rural Telehealth Evaluation Center team, has submitted a paper to Medical Care based on the results that I will be sharing with you. So this slide presents an agenda for this research presentation. I will start off with defining the haves and the have-nots, present briefly background content on rural hospitals and the benefits of telehealth, briefly discuss the study motivation, the research hypothesis and our objective, and include the research methods, the results and conclusion from the analysis, and end with our next steps. So since the title of this presentation is the classic tale of the haves and have-nots, I thought, well, why don't I start off this presentation by defining these terms? So according to the Merriam-Webster dictionary, the haves are commonly referred to as people who have a lot of money and possessions, or wealthy people. And the have-nots are people who have little money, few possessions, or poor people, in other words. So the idiom haves and have-nots is typically used when we compare the wealthy to the poor. So the have and have-not theme is not new, but we could say it's as old as time. In fact, say if you were to think back, you may have a favorite book or story that has its basis on the have and have-nots. There have been a number of classic books and stories that have focused on the have and have-nots. There are also many Hollywood movies, some of them being Oscar movies that have been made with the main story focusing on the have and have-nots. Currently, there's even a TV show which has the words the have and have-nots in the title. And for us as policymakers, researchers, interested individuals like ourselves, we have an interest in the variation that exists between the have and have-nots, because it allows us to identify disparities in the populations that we're studying. So in terms of providing background to you all, I'm sure much of this information is familiar to you, and it is frequently cited in the literature. So what I'm going to tell you isn't new, but just reiterating or summarizing what we probably already know. Rural hospitals make up greater than 50% of all hospitals in the US. They provide essential access to inpatient, outpatient, and emergency medical services.
In an attempt to mitigate these challenges that I've just mentioned in the previous slide, some rural hospitals have adopted telehealth, which provides remote delivery and ensures continued access to rural residents. So the benefits of telehealth, again, have been cited in the research and include increased patient volume, increased quality of care, reduced costs by reducing readmissions, increased patient access to specialty care, improved patient outcomes, and lastly, it has been theorized that telehealth proposes to increase patient revenue and decrease costs. So the initial purpose of our study was to determine the association of telehealth technology and financial performance on rural hospitals. So this study is the study that's been initially funded by Federal Office of Rural Health Policy and HRSA as part of the evaluation research on telehealth services. So we're still working on this research project and hope to present our results in the near future, where we look at rural hospitals and the impact of telehealth technology and try to determine, does it help the rural hospitals to become financially sustainable or another source of sustainable income for rural hospitals. In order to carry out our initial objective, which was to look at rural hospitals and the impact of telehealth on financial performance, we had to separate our hospitals, our rural hospitals, into three distinct different categories. The categories are the treatment group, or this would be rural hospitals that did not have telehealth and then adopted telehealth and continued to use it through our time period for our study. The control group, which includes hospitals that never adopted telehealth, we refer to these hospitals as the have-nots. And lastly, the always group, which includes hospitals that always had telehealth during our study period. So you can see on this slide, I've captured what that would look like, where the first one would be the treatment group. They don't have telehealth, and they turn on the switch and then they have telehealth. And then we have the hospitals over our study period that have never had telehealth, and then the hospitals that always have telehealth. So the proposed objective, again, focuses specifically on treatment and control group hospitals. That's what our initial funded research is going to be focusing on, and what we're continuing to look at right now. So this is hopefully on your screen shaded in blue. It's the first two hospitals that we will be comparing. But the presentation today is actually going to focus on the bottom two, which should be lightly shaded in red. And this research analysis is going to actually compare the rural have-nots, those that do not or never had telehealth during our time period, with those that have telehealth, the ones that I referred to as the haves. And we will compare these two types of hospitals, which are shaded in the red or the light pink. So our hypothesis for this study is that telehealth adoption in rural hospitals may be related to the financial health of the hospital, and may be related and impacted by hospital and community characteristics. And the objective of our study is to investigate the relationship between financial characteristics, hospital and community factors, and telehealth adoption in rural hospitals. The study, or the data that we used for this study, was obtained from 4 data sources. We used data from the Hospital Cost Report, which provides the financial data, the American Hospital, the American Hospital Association Annual Survey, which provides data on hospital characteristics, the AHA Annual Survey IT Supplement, which provides data on telehealth adoption, and the Area Health Resource File, which provides data on county-level characteristics used to describe the community where the hospital is physically located. This data was merged using a hospital year identifier. So just some initial details about the study sample. So our sample included rural hospitals from 2009 to 2019, which is 11 years of data. Rural hospitals were defined as short-term, general acute, non-federal facilities with special payment designations, as well as hospitals with no special payment designations located in non-metro county or sub-county areas with a RUCA code of 4 or greater. So this is a definition that's commonly used by the Federal Office of Rural Health Policy, and as well as other federal programs. Hospitals that were excluded were hospitals that, if they closed during the 2009 to 2021, they were removed from the treatment group. Remember, the treatment group is hospitals that did not have telehealth, and then they adopted telehealth during some time in this period. So they were also removed. So what was remaining in our sample was 2 groups of hospitals: the hospitals that always had telehealth turned on during the time period from 2009 to 2019, or the hospitals that had telehealth turned off or never had telehealth. So we're comparing the haves with the have-nots. Also hospitals that reported financially, or had their financial reports of less than 1 year, so less than 365 days, were also removed from the data set. So our sample contains rural hospitals. We have the always, the haves, and the have-nots over 2009 to 2019 time period. So the hospitals, again, had their telehealth during the whole time period versus those that never had them. So we're comparing the always or the control groups, or I refer to them, or I commonly refer to them as the haves and the have-nots. So we decided to evaluate the financial performance of rural hospitals, the haves and the have-nots, by using 2 measures of profitability. Our first measure is operating margin, which is a measure of profitability from hospital operations. Total margin is a measure of overall hospital profitability from both operating and non-operating sources. So when you interpret a profit margin, positive numbers indicate that a profit is being made, where negative numbers indicate that there's a loss of profit, or their expenses are higher than their revenue, or in other words, they're losing money. We also wanted to include variables that represent hospital characteristics and community characteristics. So hospital characteristics included structural factors and processes that influence operations, the strategy and revenue generation. Community characteristics describe the hospital's operating environment and market demand for healthcare services. The hospital characteristics include hospital ownership. So if they were not-for-profit, government, or for-profit, their patient mix, so percent of Medicare and Medicaid patients, the hospital size using the number of beds. The community characteristics are at the county level and include the percent seniors, the poverty rate of that county, the unemployment rate, the per capita income, population density, and hospital concentration, which is a measure of the number of hospitals in a county. So if you are in a county with 7 other hospitals, or if you're the lone hospital that's in a county. So here are some preliminary results that I would like to present to you. So this first slide presents the unadjusted average operating margin for the rural have and have not hospitals. Now remember that operating margin is the profit a hospital makes from its core operations. There were a total of 325 have hospitals, and the average unadjusted operating margin over the 11-year time period is about 1.5%, which if you were to translate that for every dollar of revenue, the hospital is making about 1.5 cents profit. There are 275 have-not hospitals, and the average unadjusted operating margin is negative 7.73 over the 11-year time period. Sorry, I'm just, did something happen?
No, you're all good.
Okay, all right, I wasn't sure. Things seem to cut out for a bit. All right, also from this slide, we can notice that there are 325 325 have hospitals, and there are 275 have not hospitals. And the average unadjusted operating margin is about negative 7.73% over 11 years. So that translates to about, for every dollar of revenue, the hospital is losing about close to a little bit less than 8 cents for every dollar of revenue that they're bringing in. So just looking at this slide, if we were to observe the haves that have adopted telehealth compared to the have-nots, we can see that the haves are more profitable compared to the have-nots, and those hospitals that do not have telehealth. So this next slide presents the unadjusted average total margin for rural hospitals, and they have the have and have not hospitals. So remember again, the total margin is actually profitability from both operating and non-operating sources. The unadjusted average total margin is about 4.14% for the hospitals that are the have hospitals. And the unadjusted margin for the have-not hospitals is about 1.35%. So this slide also kind of gives us the same results as the previous one, where hospitals that have telehealth are actually showing to be more profitable than hospitals that do not have telehealth. So this next slide that I'm showing you is the slide that presents a table where we compare hospital characteristics and community characteristics of hospital have and have not hospitals. the differences that stand out specifically on this slide are that the HAB hospitals, the ones with telehealth, are larger in size. They have more beds. A large percentage of them are not-for-profit, and they have a lower percentage of Medicare inpatient days compared to the have-nots. And these differences are statistically significant. Now let's look at the community characteristics between the have and have-not hospitals. We found here that there was also some significant differences. The have rural hospitals have a lower unemployment rate, a lower percentage of individuals less than 65 years without health insurance, a higher per capita income, a low poverty rate, and a higher number of hospitals in the county compared to the have-not hospitals. So we also ran two different regression models in our analysis. And the first regression is a Logit model. So in this Logit model, we evaluated the relationship of a hospital and the county characteristics on the probability of becoming a have rural hospital. And the results from the regression model indicate that when we compare not-for-profit hospitals and both government and for-profit hospitals, there's a decreased likelihood. Well, if we compare for-profit and hospitals and government and not-for-profit hospitals, along with both government and for-profit hospitals, there's a decreased likelihood of being a have hospital, so a hospital with telehealth. Increasing the number of beds has a greater likelihood of becoming a have hospital. Increasing Medicare patient mix decreases the likelihood of being a have hospital. Increasing percent of individuals less than 65 without health insurance decreases the likelihood of being a have hospital. And rural hospitals located in counties where you have more than one other hospital in your county increases your likelihood of being a have hospital. So this last slide actually shows this results that I'm showing you right now shows you the ordinary least squares regression results. And we did this with using robust standard errors. The model for determining the relationship of rural hospital telehealth adoption on profitability controlling for hospitals and community characteristics. So the key findings that we found here, comparing again all the haves versus the have-nots, rural have-not hospitals have an average of about 6.92 percentage points higher operating margins than the have-nots. The operating margin for not-for-profit hospitals, rural government hospitals, they have a lower average operating margin of about 4.48 percentage point, whereas for-profits have a higher operating margin of 3.39 percentage points. So the results show that there's a negative relationship between the percentage of seniors with operating margins and total margin. So from this analysis that I've shown you, what are our conclusions, right? So, well, we can see, first of all, that there is variation between the rural haves and the have-not hospitals. And what does this mean? So there is a disparity in telehealth adoption, and this has implications for access, quality, and outcomes for the residents of rural communities. We also recognize that in this analysis and the research design that we can't infer causality. We don't know if having telehealth improved financial performance or if hospitals that are more profitable have telehealth. So whichever came first, we can't determine this from this analysis. But that's what we're hoping to do in the overall objective of our paper, is to determine does telehealth improve hospital financial profitability. So recognizing that both hospitals that have telehealth and do not have telehealth are very distinct in terms of the communities that they serve and their specific characteristics. So then this, presents an interesting conundrum regarding obtaining a better understanding of what actually drives rural hospital financial performance and telehealth adoption, and what this may mean for the future as we are hopefully recovering from the pandemic. what this may mean in terms of continuing using telehealth. So some of our study limitations that I want to acknowledge are our study years included 2009 to 2019. What we found as we were trying to identify a hospital with and without telehealth, there's a lot of variation using the IT survey from the AHA data. And using that information, we created a dichotomous indicator. So what we found was there's different degrees of having telehealth. And our focus was specifically on determining there is telehealth versus there isn't telehealth. There was also a lot of variation in terms of whether a hospital consistently reported if they had telehealth or not, and also, of course, missing data. In terms of our cost report data, there's hospitals that report their financial metrics less than 365 days. So if they report it every 6 months or every 3 months, those hospitals were removed. There are also a lot of outliers in the financial data. And of course, there's also missing data. So what we this project that's been funded by the Federal Office of Rural Health Policy and HRSA, our year one objective again is to determine if rural hospitals and telehealth, does telehealth make an impact on rural hospital financial performance. Our year two study is looking at, applying this also to urban hospitals and seeing if there's other changes with using telehealth. Not only financial performance, does it improve efficiency? Does it increase market share? And our year three proposed study was looking at, in 2020, how does hospitals that have all of a sudden had to implement telehealth, those that were our have-nots during our time period, if they have to implement telehealth, how are they doing in light of having to quickly adopt telehealth and get it working compared to those hospitals that have had it over the study time period. So this is the end of my presentation. I apologize for any technical difficulties and hopefully you were able to follow along, but I think we can open it up to questions. And if you can give me 30 seconds, I'm just going to close one of my windows and take questions that are being asked.
Thank you, Dr. Karim, for the nice presentation. So Arya or Joe, are you?
Yeah, so we do have one question here asking if there is a publication or a public source for your evaluation available out there.
You mean based on this presentation?
Yeah, the findings, what your presentation was based on.
Well, there's a paper being submitted right now to Medical Care Research and Review. So it was submitted last month, and fingers crossed that it gets published and we could share our results.
Great, awesome. Yeah, everyone else feel free to use the Q&A function to ask any questions. Here's one. Let's see, what is the study specific to certain times of telehealth or varying, like use in stroke, burns, OB, etc.?
So we don't have that information, and I don't know, Hari, if you can add to this. We just have, whether a hospital has telehealth and to what extent they've implemented it. So not specific in terms of whether it was used for OB or, like, for instance, stroke or anything. That level of detail or granularity wasn't included or available in the data.
Hari, did you have any comment on that?
No, I think, yeah, we don't have that granularity yet.
Okay. Let's see, we have another one here. Could you discuss the hospitals owned by the government a little more?
I'm not sure what what they are.
Let's see, on the slide where you had it broken down, the have and have-nots, you had it broken down by nonprofit, for-profit, and government. I'm assuming that's the slide they're referring to.
So if so the question coming from is just in terms of its ownership. So one of the things, hospital financial performance depends on is the type of ownership it is. So if you are a for-profit, your goals to increase shareholder wealth, and your decisions you make would be different compared to if you're not-for-profit. Now, not-for-profits can be public not-for-profit hospitals. For instance, an example would be a children's hospital. And then you have government hospitals, which are community hospitals, state facilities, for instance. And so the different types of ownership influence the funding that's available, the type of patients that they see, and their financial decision-making that they would make. There are limitations in terms of if you are a government or not-for-profit hospital, the sources of financing, for instance, that you're able to obtain versus, say, a hospital that's a for-profit hospital and where they could obtain additional financing.
Yeah, and the question asker followed up with saying there were considerable differences in terms of telehealth being used, and you just answered it there, but also I think you mentioned it in your limitations as far as the different identifiers as being a barrier to your study. So I'm curious, as you're talking, I kept thinking about the dates 2009 to 2019. Obviously, after 2019, the landscape changed significantly. What are your thoughts on that? Like, how do you see your results in your study here? Anything different that you see coming out of this?
So one of the things that I think we need to be mindful of in the results that I've shown you is that there's hospitals who, this is what I see based on, knowing finance and, knowing this material, is that wealthier hospitals are able to invest in certain technologies or capital investment compared to those that don't. So if that's the case, then, the hospitals that don't have the financial resources are not able to invest. And so, going forward with the pandemic, it's trying to see, well, how do these hospitals become sustainable? How do we make sure that these rural facilities that can't afford to invest in this type of technology or other type of investments, what can be available to them? Are there special types of loans that could be available to these types of facilities? And so to help them, again, reduce that disparity, creating more equity between the rural, because now you see that there's this difference just in rural hospitals, those that have and those that don't. And, the title that I came up with was, while you have rural hospitals that have and have not, it's really about the rural hospitals that have wealth versus the rural hospitals that don't have wealth. And those that don't have wealth are just at a disadvantage. And so it's like, what do you need to provide them? Maybe as policymakers, government, are there low interest loans? Is there a way that these hospitals can take or be given the opportunity to apply for certain types of funds so they can invest in that technology? Otherwise, they're in this spiraling circle where they will never be able to, on their own, with what they're making, with the money that they generate, to be able to invest in these types of technologies.
Oh, thank you for that. We got a few more here. From a statistical point of view, there might be some other reasons that make the margins of the hospital change over time. And then the utilization of telehealth is related, but it's not a causal reason for the hospital's margin change. Can you comment on this thought?
I guess, can you repeat that question? I'm trying to understand what is actually, it seems like it was more a comment. So I agreed. I mean, there are some, like this model was, again, there are a lot of things that I'm not controlling for. And, but if the person can expand more on what the question is.
We'll leave that out there and see if they can expand a little bit more. We have another one here. Did you look at state policies or state level variation in the relationships between hospitals, the have and the have nots in telehealth, maybe adding state fixed effect?
No, so I did add hospital level fixed effect. I didn't add any state level fixed effect. So that would definitely be probably a way to control for the unobservable time invariant bias that would be there. But I did use fixed effects, just looking at the hospitals over time.
And we do have a comment here. I know in Arkansas, the trauma system and stroke program actually bring money into the rural facilities with telehealth. I can see how a study specific to our state comparing the have and have nots would be very interesting. Thank you for your presentation and data.
Appreciate it. I appreciate the feedback. I mean, one of the, I guess, the challenges of working with this type of data, being national, cleaning it, it's publicly available, so it's not, you know, in its best form. So, you know, there's a lot of assumptions that are made and, you know, stating those limitations in our paper. But we're hoping that with the actual objective of the paper to really see if, you know, if rural hospitals are making money off of telehealth. And if they are, this could be maybe a way for rural hospitals to, you know, that don't have telehealth, or how to keep it sustainable. That's another question I think we'll have to determine is, you know, once this pandemic, maybe, I don't know if it'll wrap up, but, you know, maybe come back to some sense of normal, if telehealth will still be as in demand as it was, you know, during the pandemic.
And we have a question in the chat box here. Was there a difference in region in the country as to adoption of telehealth during the COVID period?
So we are hoping to get data for that. So we don't have data for the 2020 when COVID happened. So our data, our analysis focuses on 2009 to 2019, just right before COVID happened. So what would be interesting is to see that those that had telehealth during that time period, and they continued having it during COVID, versus those that had to quickly put it into place, and how they fared. I mean, if you have it, there's probably less of a learning curve, and you're probably able to adapt more quickly to using telehealth and continuing providing care without any disruptions, versus those that didn't, and then had to all of a sudden, you know, access the technology, put it into place, learn how it works. So, you know, that again would be an interesting question to review.
And then sort of in the same vein, for your study and time period of your study, was there a difference in adoption of telehealth based on the region and the nation?
Oh, we didn't check by that. One of the issues that we've had with this data set is like one of the things I presented was the low number of rural hospitals where we had complete data. So if we were to break it down by, you know, region or state, I think we would have very few to actually be able to make any conclusion. And that's more of a data issue, because we've had hospitals within our data set that would, you know, they would fill out the IT survey or they wouldn't fill out the IT survey. So, you know, finding a complete 11 years of hospital data actually ended up eliminating hospitals that would only fill it out for like 2 years and then not fill out the survey. And the survey, again, the AHA survey is, it's a long document. So I'm sure whoever fills it out probably got tired and decided not to fill out the rest of it. So that's an important question, but we just don't have the data unless it's collected somewhere else.
Thank you. Dr. Karim, I'm not seeing any more questions or comments. Thank you so much for your presentation today. Dr. Aswaran, thank you for being here. And I'll turn it over to Arya.
Thanks, Joe. Just a reminder that our next webinar will be held on Thursday, July 21st, and that will be hosted by the Pacific Basin Telehealth Resource Center. More information will be posted on the events page of the NCTRC website soon. And then lastly, we do ask that you take a few short minutes to complete the survey that will pop up at the conclusion of this webinar. Your feedback is very valuable to us. Thank you again to Dr. Karim for her presentation and to the South Central Telehealth Resource Center for hosting today's webinar. Have a great day, everyone.
Thank you, everyone.